Hello everyone, I'm Dr. Angela Mattke, and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center, and twice per month I host a show about pediatric health topics where we take and answer your questions live. Today we will be discussing spina bifida and how prenatal surgery for spina bifida, also known as fetal surgery, can be performed in some cases. Spina bifida is a condition that affects the spine and is a type of neural tube defect. Joining us for this discussion are two highly gifted Mayo Clinic Children's Center surgeons. Our first guest is Dr. Edward Ahn, a pediatric neurosurgeon and professor of neurosurgery and pediatrics. Our second guest is maternal fetal surgeon Dr. Rodrigo Ruano, who is a professor of obstetrics and gynecology. Dr. Ruano is also the director of Fetal Diagnostic and Interventional Center at Mayo Clinic in Rochester, Minnesota. It's going to be a great discussion today, so please send in your questions under the Facebook Live video feed, and we will try our best to review them during the live broadcast today. So Dr. Ahn, Dr. Ruano, thank you for both coming back. You've both been on this show before.
Thanks for having us.
Yeah, but this is a new topic and a really, really fascinating topic that we're going to be discussing today. So let's get started by just laying groundwork for us to understand what exactly is spina bifida.
Spina bifida is a birth defect where the spinal column does not develop normally. It all happens during the first month of gestation.
Okay.
So if the spine doesn't develop normally, then you can have absence of the bones, you can have absence of the skin, and we're going to talk about today the most severe form of spina bifida. And that's something called a Myelomeningocele, and it is where there is no skin, no bone over the spine, and the babies are born with their spinal cord exposed.
And we have a picture of that. Let's pull that up so we can kind of see what it looks like. Can you talk us through this myelomeningocele?
Right, so what is shown here is the normal spine on the left side, and on the right side you see that there was a failure of formation of the skin and the bone on the back, and literally when the babies are born you have exposure of all the nerves, the spinal cord, to the open air essentially. And you can imagine that even during pregnancy, during the remainder of pregnancy, that the spinal cord is vulnerable to the amniotic fluid, to the to trauma, and there could be problems with the functioning of those nerves.
Okay. And so children are going to probably need some surgery to kind of help repair this because of the spinal cord being vulnerable.
Right.
Can you talk a little bit more about what would be the consequences of having this kind of birth defect where the spine is protruding out?
Right. So the spinal cord protruding out during gestation has a number of effects. So one, we know that the spinal cord is affected because it's exposed to the environment. In that case, it's the amniotic fluid. We think that has some toxic effect on the spinal cord. Also, the fetus is moving around, and we know that might have some trauma effect. And actually, if you look at the fetus developing throughout the pregnancy, there is some evidence that the legs begin to move less and less throughout the pregnancy. So there is some effect of that happening.
Okay. There's definitely progression of the disease in utero. So.
Right.
Okay.
And then what's important to know is that spina bifida not only affects the spinal cord itself, but the effects are from the bottom all the way up to the top, including the entire nervous system.
Okay.
So we have a graphic that shows the nervous system and the potential effects. I believe it's the next slide there. And if you have the spinal cord exposed on the back, and there can be an exit of fluid that normally surrounds the spinal cord, and you can imagine that happens throughout the development of the fetus, and then that pool of fluid through the back then affects all the way up top to the brain. And these fetuses also have evidence of what's called a Chiari Malformation, and that is part of the brain called the cerebellum is coming out from the head itself and then going into the spine. And then that can cause problems. That can cause developmental issues with the brain. The brainstem is right next to the cerebellum, and there can be pressure there. And then also the fetus can develop what's called hydrocephalus, and that is due to a blockade of the exit of fluid out of the brain. And there can be buildup of fluid inside the brain causing pressure. And water, or the term hydrocephalus means water on the brain, can build up inside and then the fetus can then have some damage to the brain if because of the pressure building up.
So before the development of fetal surgery or prenatal surgery, when was the timing of the surgery performed, and why was that significant?
So typically the babies are born, and what you physically see is the spinal cord exposed. So we have also a graphic there. And you see that the spinal cord is exposed through a cyst on the back. So there, pictured on the left, is a newborn baby with the Myelomeningocele, which is the open Spina Bifida. And what we would do as neurosurgeons is we have to repair that within usually the first day of life. So after the baby's born, we're bringing him to surgery, and then under anesthesia we fix that defect. And we can show a video that shows the various steps of how that is fixed. So there you see the cyst, and we remove a cystic layer that's covering this spinal cord, and there's the very end of the spinal cord. And then that has to be placed back into the spinal canal and fit back into place. And then we cover various layers of tissue over top. And these are all areas that were never developed or never closed during development. And we close them surgically. And then we finally bring the muscle and then the skin over top of the spine to create the closure.
So which patients would be candidates for having prenatal surgery? Because you mentioned that there's progression in utero of some of the symptoms that you would see, and does this relate to when you would do the intervention, either after the baby's born or fetally?
Yeah, so nowadays we can offer intervention in utero before those babies are born, because exactly what Dr. Ann mentioned, we believe that there are two heat processes. The first is that the spine doesn't close well, so we have some damage of the nerves. But also the contact with amniotic fluid can cause more inflammatory reaction to the nerves, causing more damage. And also the leakage of fluid from the defect can push the brain down, and it can cause a Chiari Malformation. And then if the baby moves, of course, we can have trauma. So if we can avoid that, the second heat process would be fantastic. But your question about who would benefit from this procedure, the most severe forms. So we usually do fetal anatomy scan around 20 weeks, which is a screening for all pregnant women. And then we diagnose that situation nowadays with good accuracy, so good precision, and then we have a multidisciplinary team evaluation. We use MRI to help us, but we need to confirm that is an opening problem, Myelomeningocele, as he mentioned, and with Chiari Malformation. Usually we offer the procedure from until 26 weeks. And then recent studies the studies have shown that the real benefit is to restore the Chiari Malformation, so the Chiari Malformation regressed, came back to the normal anatomy, and then the chance of hydrocephalus postnatally decreased. So with fetal surgery, we reduce from 80% without the intervention or postnatal intervention to less than 40% of those babies will have severe hydrocephalus. So we really stop the progression of the disease.
Okay, so one question families might have is, why wouldn't you do a fetal intervention with all infants? Why just only the most severe forms?
That's a great question, because we have some risks related to the procedure. So, for example, some of those mild form of Myelomeningocele or myelocele, or different types of Spina Bifida, we don't see Chiari Malformation, so the posterior part of the brain is not pushed down. And then those babies, they have good outcomes. So the chance of having severe hydrocephalus is lower. So then the risk of doing the fetal intervention that can be higher than the benefit. So we usually offer this procedure for more severe forms.
Okay, and just to reiterate, you said the timing is around 26 weeks is when you would do the fetal
22,
surgery?
26 weeks. We prefer around 25 weeks, our team here.
And why is that time? Why is that so specific within that frame?
Well, technically, it's very complicated to do before. Second is the diagnosis of this problem
Mhm.
is usually made around 20 to 22 weeks.
Okay.
And third, we like to have bigger babies in case, because one of the risks is preterm delivery.
Mhm.
So if we have a preterm delivery, the baby can survive, because nowadays the viability is higher than 24 weeks. So we usually, our group has decided for around 24, 25 weeks.
Okay. And one other thing that people might understand is we're talking about a fetal surgery where the infant is going to stay in utero hopefully longer and grow,
Exactly.
right? Is that so? At what time period would the moms usually go into delivery then?
Yes, that's a good question. So we usually do the procedure
Mhm.
at 24, 26 weeks, and we follow those patients weekly. And the procedure we do in combination with the neurosurgeon is a big group. So we have neurosurgeons closing the problem exactly the same way that we saw.
Mm-hmm.
That they do postnatally, we can do prenatally. We open the uterus, and then the neurosurgeons, they close. We have pediatric anesthesiology, maternal anesthesiology. We have a big group. And then we follow weekly those patients, and usually we deliver them at 37 weeks.
Mm-hmm.
But now we have a different solution for that. We can do the fetoscopic repair. We can put tiny telescopes, and we don't need to open the uterus. And those patients can deliver even further, or at 40 weeks, and they can even have vaginal deliveries.
Wow, that's incredible. Well, okay, you mentioned that there's a lot of people involved. So obviously pediatric neurosurgery, pediatric fetal medicine, and pediatric surgeons. Who else?
Obstetricians,
Obstetricians.
maternal fetal medicine,
Okay.
specialized in fetal surgeries.
Mm-hmm.
Then we have anesthesiologists, neonatologists. They're
Mhm.
involved in case
Mhm.
we need to deliver the babies. Very rare, but we need to be ready for that.
Mm-hmm.
So, and we have all the team behind with the nurses, etc., etc. So.
Okay. And then after these children are born, there's going to be another group of team caring for them. Who else, Dr. An, is involved for the care of children who
Well, we have a
Spina Bifida?
multidisciplinary group that comprises what's called the Spina Bifida Clinic. So these are children who are repaired either prenatally or postnatally, that they are evaluated in this clinic whereby they're seen by multiple specialists. So
Mhm.
there's a coordinator, a nurse coordinator who kind of assembles the entire team. So you have neurosurgeons, you have orthopedic surgeons, you have urologists, physical therapists, neurologists. I mean, it's a big team of people that care for the children. One important consideration is that to think about why pursue a prenatal surgery, because we're
Exactly.
talking
That's
about
very
a big ordeal.
Mhm.
And it's important to know that with the standard of the postnatal treatment that we talked about after the baby's born, that the babies are dealing with a lifetime of potential issues, and that is not only problems with the spinal cord, which can leave them with weakness in their legs, their feet, potentially not being able to walk, but also problems with their bladder, so not being able to empty their bladder. So these are, and then we talk about the effects on the brain itself with the hydrocephalus and potential developmental issues. So these slew of issues make us think that, well, can we do something better by arresting that process earlier? So that's why a number of centers have looked at prenatal surgery and its benefits.
Yeah.
Yeah, we have even a randomized control trial, which is the highest medical evidence,
Mm-hmm.
proving that prenatal intervention compared to postnatal intervention improve the outcome for those kids, for those babies, because of exactly what he's saying. So the chance for hydrocephalus decrease a lot, significantly.
Half.
Half.
Wow.
So they can have better cognitive development. They don't need shunts or postnatal surgeries, and
Mhm.
sometimes they don't even stay in the NICU. They do very well. So there's clear evidence that the prenatal surgeries can improve the outcome for the babies.
So in 2011, there was the publication of a randomized controlled trial where the mothers were grouped into either a prenatal or postnatal surgery. They were randomized into the two groups, and then they actually stopped the trial early because of the benefit of the
Wow.
prenatal surgery. And those benefits are what Dr. Ruano mentioned was that that fewer babies required the shunt for treatment of hydrocephalus.
Mhm.
That those babies had fewer Chiari malformations, that you could actually see the Chiari malformations go away prenatally. And also, there was a benefit for their motor strength. So their legs worked better, and they were better walkers. So all those benefits were shown by an early prenatal closure.
And we can even see before the babies are born on ultrasound and MRI. So usually here we repeat MRI 6 weeks after the procedure, before the babies are born. And we can see clearly that the posterior part of the brain, as I mentioned before, comes back to the normal situation. So, and also we can see movements of the legs that we are quantifying now, which is kind of the same that we do postnatally, but we can see the improvements.
Okay. Well, let's talk a little bit more about what's actually occurring in the surgery.
Yeah, so the surgery that we do is a big surgery. So we do a general anesthesia because we need to relax the uterus. The standard of care now is to open the mother's abdomen, the belly, expose the uterus, and we find a place and we do a 2-3 centimeters incision, and then Dr. Ann's team comes and work and close the Spina Bifida defect exactly the same way that we do postnatally. This procedure has proved to improve the outcomes for those babies, but has some risks or complications that can happen to the mother. So that we need a very specialized group to follow those mothers even before doing the pregnancy. But now we are offering a less aggressive procedure that we call Scopic surgery. That we just put 2 telescopes, and we have a video that we can show that too. So usually we use ultrasound to map the placenta, the location of the placenta, and then we map and position the fetus with the back up, and now we just put gas, and we remove a little bit of fluid, amniotic fluid, and we put some gas just to expose the back of the baby. And then we have a situation, environment with half fluid and half gas, and then we introduce 2 or 3 tiny ports, 2 millimeters, and then Dr. Ann proceeds with the technique.
So through these ports, we use these tiny instruments then to repair the spine defect. So we close the various layers over top of the opening and then close the skin through just those 2 ports. And the idea behind this procedure is that we're avoiding that opening into the uterus, that just through these 2 small ports, the uterus is minimally affected. And we can then see the advantage of basically two major advantages. One is that our idea is that the babies can go to term. More likely that babies go to term. There's less disruption of the uterus with that procedure. And then secondly, the mothers can have a vaginal delivery afterward, which was not possible with the open prenatal repair, that all the mothers had to have a scheduled C-section.
Exactly, because if you do an incision during a uterus that is growing, of course we cannot have the patients laboring or have contractions.
Because there's a risk for uterine rupture, is that right?
Exactly, uterine rupture. So that's why we need a very high specialized group following these patients. But if we do the scope, through the scopes, those patients can have vaginal deliveries.
How long has the procedure been going from where you did the fetal intervention open versus the fetoscopic intervention with the little tiny ports that you're using?
That's a very interesting question, because in the beginning, in reality, some of our colleagues many years ago tried to do the scope, but it's very challenged. The technique is very challenged, so it didn't work very well.
Right.
Then they established the technique, the open technique, and then it's very recent. I think 2 or 3 years ago we have started again to try this fetoscopic with a different approach, less aggressive, less invasive, and using more sophisticated instruments.
So Dr. Ruano and I are collaborating with 3 other centers to perform the fetoscopic repair, and this is something that, as he said, was introduced a few years ago. This technique, and now we have an FDA-approved trial here at the Mayo Clinic to offer this approach. And it took a lot of work, and we have a huge team involved, and it took a lot of practice, so to speak. So Dr. Ruano and I both visited the centers that are doing the procedure. We both spent countless hours on a simulator. So we actually have a simulator that with the uterus and the baby inside, and we've done the procedure through that, and we've now been able to offer it here at the Mayo Clinic.
That's fantastic. If families find out this diagnosis, how would they get in contact with you for the evaluation process?
Yeah, we have our fetal center
Mhm.
number that I can share with you afterwards, but and then we can get them here, and then we
Mhm.
can have the multidisciplinary approach that is very important, evaluation that's very important.
You talked about some of the advantages already, but we also have a diagram on slide 7 about kind of like the outcomes. Let's pull it up and you guys can talk this through with us.
This is
Go ahead. No, go ahead. This is
Yeah.
a very good example of the in utero intervention because the healing process is fantastic.
Yeah,
So,
so
good.
of
yeah, if you
course, we need to
compare-
have a good surgeon like Dr. Mann.
yeah, but if you compare a fetus to a child or an adult,
Uh-huh.
the healing potential of the skin is amazing. So very little scarring. So this was a picture of a newborn baby who underwent a fetoscopic repair, and originally, as you saw previously, the spinal cord and everything is exposed and open, and this is the result after the baby's born, after we repaired the defect in utero. And you can see that there's minimal scarring and there's no defect at all. Everything, all the layers are closed inside.
This is an incredible outcome. Wow, I'm just blown away with how good that looks. So after the baby's born, so if you've already done the repair, are there other surgeries that this child would be needing, as like neurosurgeries versus other surgeries?
Certainly, I mean,
Yeah.
we monitor these children just as if they were closed postnatally as well.
Mhm.
So all the risks that I described previously, the hydrocephalus, the risks of weakness on the legs. I mean, they're monitored for all of these things by our multidisciplinary team. So typically what happens is the babies are born, and then we monitor them for about 1 or 2 weeks in the hospital, and that is to check to make sure that they're not developing hydrocephalus. There's still a risk for that. So there is a potential of requiring future operations to reduce the pressure in the brain. And then depending upon the strength of their legs and the function of their spinal cord, after that they may require future procedures for their legs, for their bladder, depending upon the function.
Okay. I imagine that possibly their time in the NICU is going to be less with this fetoscopic surgery as well. Has that been shown?
Yes.
Yeah.
Yes. So that's we still sending the patients to the NICU, to the neonatal intensive care unit, because we wanted to be sure that the babies are doing okay. But our experience here is that they stay very short, like short time there. We just want to be sure that the skin is closed, like Dr. Ann mentioned or showed, and then if everything's okay. So usually they stay very short time in the NICU.
The idea behind that is if the babies are born prematurely, then they usually have a lengthy stay in the NICU in order to get them back up to speed with their breathing and feeding and so on and so forth. But if we can carry the babies closer to term, then their stay overall in the hospital is much shorter.
Yeah, they're going to be born ready, knowing how to eat probably much better and growing better, which is going to be probably better for their outcomes as well. So.
Yes,
Yeah.
on many fronts, yes.
Yeah, absolutely. So what is the recovery like for mom from this process, and what is it like for babe as well?
In utero surgery?
Yeah.
Yes, for in utero surgery, the recovery is still we are fighting against uterine contractions.
Okay.
So we need to be we need to control the contractions. So we need to give medications, strong medications to stop those contractions. So for 1 or 2 days, this is our main goal. So, but usually we keep for fetoscopic repair. We usually keep the patients for 3 days in the hospital. And for open surgery, they stay a little bit longer because it's a bigger incision.
Okay.
But then we follow weekly
Yeah.
in our clinic, and 6 weeks afterwards we do an MRI, and we have the entire team seeing the patient again.
Wow, that's fantastic. Well, we're getting nearing the end of our time. So do you guys have anything else that you'd like to share with our audience about this procedure and the outcomes as it relates to these babies?
Well, one thing I wanted to share was that that we clearly talked about the benefit to the babies, and I wanted to talk about that. Just working together with Dr. Ruano and taking care of these babies and their families has been I've experienced the benefit to us, and that is being able to meet these families, and that is probably one of the most inspiring aspects of our work, and being able to meet the families who. We meet them pretty fresh after the diagnosis, so the mothers get diagnosed, and the families are dealing now with the issue that they're going to have a child with a birth defect, and they know that the birth defect can be very serious, as I described before, about the potential for not being able to walk, not being able to control the bladder, potential for brain issues, developmental issues, and then they are sort of in the cloud of all of that, the news being delivered to them about that. And then they hear about the prenatal surgery, and then we get to meet them. And then by that time, they have, the families, the couples, the mothers have all decided that we're going to do whatever we can with this news that we got to make this child's life better. And that includes all the steps that we described, and that includes the mother then deciding, I'm going to get surgery. And if it means that we can offer a benefit for my child, then we're going to do it. And that to me has been the most inspiring part of this.
Yeah, I would like to echo what he's saying and Dr. Ann is saying. Of course, I have been doing this for many years, but it's very important to consider the mother. So that's why we call maternal fetal surgery, because the majority of those patients, they are healthy, but this is a very challenging situation. And I think we need to provide hope also with science, with the correct situation. But information is very important. So before we decide to do the fetal intervention, maternal fetal intervention, we need to have the entire team together. And that's what makes our team very strong, I think. And then we partner with them on this journey since we have the diagnosis, which is a very challenging situation for them. So I echo what you're saying.
Yeah, it's beautiful to hear about the journey that you guys have come through and what these families go through. So thank you for all that you've done and all that you've done to advance this field too. So it's beautiful. So thank you. Yeah.
Thank you.
Thank you.
Thanks for joining me today as well, and thanks for sharing everything that you did with our audience today. And thank you everyone who watched. You can catch the next Ask the Mayo Mom Facebook Live video question and answer session. It'll be in the new year 2020 on January 9th at 11 a.m. Central Standard Time. The topic will be pediatric rhabdomyosarcoma, which is a rare but serious cancer that 3 experts in our Mayo Clinic Children's Center will be discussing with us. Dr. Candice Gramberg, Dr. Patricio Gargoyo, and Dr. Carola Arndt. It'll be a great discussion, so please join us. And thank you everyone who watched and sent in questions. Have a wonderful day.